Thanks a million for having me there, Martin. So as I said, we were one of the early people who got through the living lab process with you, and it was all pre-COVID. Um, but I suppose COVID, even for ourselves, has helped us for people to understand what's possible more so than the service. But teledermatology isn't a new thing. It's around a long time. It's basically taking photographs of skin for consultants to diagnose remotely. And but the one thing we found, for me, it came from a personal skin issue. I was a private patient, couldn't believe how many months it took me to be seen and surgical and whatever. Um, I just thought this was unbelievable. So when I started researching and looking into it, as I said, Dr. Barry was a partner with me. Um, we very quickly found that consultants just didn't trust the image quality coming out of teledermatology products. So we set up to kind of look what was in the market, and then we ended up actually building from scratch a very bespoke model, which, as I said, has been quite successful for us now. So we started back in 2017 just as a concept and exploration. As I said, it came from a personal experience I had. My business is always background of technology. So, for me, it was, well, technology can solve this problem. Consultants disagreed with me at the time. By 2018, we began technical design and building of prototypes, modeling. We had, as I said, one or two dermatologists on board. We had a group of GPs, we had business people and technical people that we brought together to try and see, how far can we take this prototype. By 2019, we were running a pre-pilot in St. James's Hospital that lasted 3 months. I'll show you some of the data later on that. And we had about 5 consultant dermatologists on board at that point. It was still very much in a pilot phase, but at this stage we had really started to invest money into it and take it as a real serious option. We had one scanning center that we used for pilots, and then we had a GP program that we tried. We thought we'd initially, so our equipment, I'm not going into too much deep, but basically our equipment we bespoke built ourselves here. As far as you're aware of the technology we built, and we decided to be very good if GPs could have this in their own surgery and connect directly with the consultant. So that pilot ran, an honestly even unsuccessful pilot where it just wasn't being used. GPs were still referring, and when the ones who did use it, quality wasn't great. So we decided that had to be looked at. So at that stage, 2020, I guess we approached you guys in the HSE in the Living Lab, and you looked at our technology, and St. James's decided to do a pilot with us. And at this stage now, we had actually fully built our platforms and our technology. So it's just putting it all to live test. That ran over 3 months. We had about 150 patients through that program, and about 180 lesions went through that. We got approved then on HealthMail and HealthLink. After passing that pilot, we also did some NTPF project work with the RCSI group. We opened up ourselves for private patients and covered by private insurers. Then we had about, as now, 11 consultants on board, dermatologists came over and started using. So it really quickly started to snowball across the consultant network that this was actually a tool that they could stand over. We opened up 22 scanning clinics across the country. They're both used for private and public work that we do. We're ISO certified, and we got awarded Best Use of Technology, the Irish Healthcare Awards, which was obviously a big win for us for such a new technology. So the real issue is currently, and this isn't just an Irish problem, by the way, but currently GPs referring a written referral. So if you're going to see your GP, this is a very well written referral. For a patient with something on the side, the face has a previous history of skin cancer, and the same referral can mean many things. So this is where it gets a little bit graphic, just for anyone who's a bit queasy. So looking at these 4 issues, currently all 4 must see the consultant face-to-face to get a diagnosis. The reality, only one needs to see the consultant. The rest can be managed remotely. So that is the real power of having very high quality teledermatology. I just spent the morning on the NHS consortium that we're part of, and about pictures coming from GP practices and how blurred and out of focus, and the consultants can't make a diagnosis. Like, we discovered that early on with our GP pilot, hence we opened up scanning centres that are nurse-led. The nurses are highly trained how to take the images, take more medical history than comes off the GP referral, and give the consultant the full model of data they need to actually make a diagnosis and not just an opinion. So sample photos that had come in the same pilot we ran in St. James's, photos did come in with some referrals. These were some of them. And as the consultants would point out, they can't do anything with those. They're either black and white, they're not clear, they don't know what they are. The NCCP and HealthLink did a pilot with GPs, about 180 patients, 3% were kept out of the hospital. These are the images that come off the Dermview technology, so you can see a clear difference in the level of quality. And the most important are these dermatoscopic images. Dermoscopy is a kind of something that the consultants would use in hospitals. This is a standard dermatoscope, but there's training involved in using this and getting that level of image. But that gives a consultant an absolute immediate view of what they need to do. And this is a melanoma, so this goes straight to surgery. So our HSE pilot results, we had primary endpoints that were done with technical, and then the secondary endpoints were medical. Dermview weren't involved in collating the results, so the technology was used in St. James's Hospital. There was 5 consultants. It was run by their nurses in their own urgent lesional clinic every Friday. So macroscopic images from the system, acceptable 99%, dermatoscopic 97%. Teledermatology able to make a firm diagnosis, and I guess this was the knockout for us, 99%. That's well above the international norms. Telederm to face-to-face correlation was 96, yet that was done where consultants, in a lot of these cases, 2 or 3 consultants saw the same patient individually. They went in, saw the patient, first of all, they reviewed the teledermatology and made their decision and locked that down into the computer. Then they went in and saw the patient face-to-face. And in some cases, patients were seen by 3 or 4 consultants on the same day, using the same model. And then they came out and gave their opinion. And the only difference was cross-correlation of, was it a benign wart or a benign SEB-K? Then our number of patients seen, our direct discharge from this, and remember this was the urgent lesional skin cancer clinic in St. James's, we had a 55% direct discharge, and rerouted back to GP care, 14.5. So we ended up with 35% actually only needing to see face-to-face with a consultant. And that's a huge number when you think of the waiting list nationwide, currently at over 45,000 patients in the public system. So an example flow of how it works, 1,000 patients, example, would come in and have teledermatology triage. And that's done by a nurse-led clinic. On average, 510 to 550 actually never see the consultant. And then the returning patients, and this is where I suppose the technology in the background really enables this. So we can redirect the patients. So the consultant there and then can redirect the patients immediately to plastics, to biopsies, to MaxFax, long-term care, and they can choose the consultants they go to in the platform. So that all triggers in the background very, very quickly. A consultant takes 2 minutes, 3 minutes to actually do each patient case. And that includes the onward referral pathway for the hospital. So it becomes very, very time saving for the hospital. Our data, we've proven consistency. As I said, we only went live with this a year ago, and we've just more than that now at this stage, probably close to 2,500 patients through it. But as you can see, the data across, we did a pre-pilot, our St. James's pilot, an NTPF project, and then our own privates. But our patient numbers, our discharge, our hospital face-to-face and GP-led care are almost the same in every one. So we know what we have is absolutely highly repeatable. So I suppose the benefits of teledermatology, for a long time, consultants fought it. You would still find that in reality. Certainly any new consultant come back from the UK has had dabbled with some type of teledermatology. And we know from even our UK work that we do, the level of images and data that's coming off our system outweighs anything in the market at the moment. But it's potentially rapid reduction of waiting lists. Over 50% of the people don't need to be on the lists, and they can be rapidly discharged. It enables a staunch care model of care closer to home because they come to a primary care centre or a GP practice rather than actually coming into the hospital. And patients will avoid unnecessary hospital visits out of that. GP education is something that came out of it, wasn't planned, but we've heard a lot of GPs giving us really good feedback because they get a copy of your results, full colour of the images of the GP's consultant's diagnosis. So, and that all happens within a number of weeks, the patient actually, the minute from being referred. So if patient was referred today, this process will be done within 2-3 weeks. So they're getting those images back at that level very quickly. There's a very much of a green dividend, reducing travel into hospitals and less disruption for the patients seen locally. So in 2021, I suppose that's where we are now. We were just awarded, and this is very much thanks to the guys, you, Martin, and your team for backing our pilots and backing our data and testing our data. And it stood up when we went and tendered, just an open tender for the HSE. We came first place for all non-invasive diagnostic testing in a new tender that's just about to be launched nationwide. Dermview's led that across just by the use of our technology and the amount of patients we can get through versus the traditional model. We've also just been awarded an NTPF project with St. James's Hospital. We're going to take their entire waiting list off the next 24 months. We now have 26 consultants on board, and that does include dermatology, plastics, and MaxFax, and allowed us to reroute patients from a derm can reroute to plastics or MaxFax for surgery. Ourselves privately, we've 18 surgical locations, and we were chosen this year to be part of the NHS UK project of 25 by the year 25 is Skin AI. So it's the next generation of what we're really doing, and it's putting AI behind the images and technology. So within 25 minutes by the year 2025, the UK hope to be able to give GPs back a diagnosis on a patient from the GP. Dermview were chosen that again for our image quality and data set. We're not building the AI, there's AI partners in there, but from basically taking, AI won't work without really, really good images, and we're chosen on that basis. So I'm keeping it nice and short because I know time is really short. So the future for Dermview, dermatology, we're now moving into HSE demonstrator mode and discussions with hospitals and actually using the technology in-house. Currently, we offer a full service to the HSE and NTPF models where we actually do everything for them. But this is actually using the technology themselves in-house. Our platform is being adapted and we're back in living lab stages. We talked to the guys and partner with some others around ophthalmology to do the same thing of rapid triaging and diagnostics remotely. And we've surgical clinics that we're growing. And as I said, we're working with different countries in Europe. NHS been heavily involved in that project, but we're talking to other countries around taking on the technology into their hospitals. So that's basically the short history of Dermview. It's been short, it's been about 5 years, but it's come a long way. And I guess like COVID hampered us effectively, in our view, hampered us a little bit at the start, but we had a really, I suppose, good win out of it when St. James's Hospital in January this year, all the hospital derm departments were closed down. And we just sent them an email and said, look, guys, you want to stay open, reroute all your patients to any of our clinics you want. Your nurses can work out of our centres and your consultants know how to use our technology. And they kept the entire derm department running at full tilt right through COVID. Obviously with COVID restrictions and slightly less numbers, but every urgent patient got seen. So it was that was a bit of do good on our behalf, but actually it was a great thing for us to do. So that's it. Thank you very much. So any questions you can ask?
Thank you, Owen, for a really compelling presentation. And it is interesting to say this is, for your experience as a patient in terms of the waiting list that drove you actually on this path. And we know, for example, in the semiconductor industry that 70% of the major innovations in the last 30 years actually came from lead users, and we're starting to see this pattern happen now in digital health. And actually we'll hear this from Angus in a couple of minutes, but just to say we're so pleased to see the progress that you've made in dermatology. I know you mentioned there was now 45,000 people on waiting lists, and that is a really key area of focus. So we look forward to Dermview being, a huge part of actually reducing those solutions. But in the stay left, shift left, this is a brilliant example of it in the quadruple aim. There's lower cost, there's probably better quality of care, there's better quality of life, and there's a better clinician experience. So, it's brilliant work, and really look forward to continuing the partnership. Great, thank you.